when you stand up on a podium this late in the afternoon, I always remember an anecdote from Indian history that a gentleman went to a war and then, he got the arm of the soldier. And then somebody asked him that, I thought the norms of the war are that you're supposed to get the head. He said, somebody else got to the head before me. So I guess enough has been said about it already, so. But we'll try to change our stance. I think that we could. I'm trying to figure out this guy first. फॉरवर्ड कौन सा है? नहीं चल रहा है. No. Okay. All right. Sorry about that. So I think the talk that preceded was actually a really kind of setting up the stage for this. And while I was listening to Professor, I remembered our days with zinc. We had the same dilemma. Zinc can impact 230 enzymes in the body. And then if you are really trying to understand which of those is the mechanistic possibility of a particular action, it becomes difficult. Which doesn't mean that we shouldn't try it, but it becomes difficult. And I think that was part of the talk that we had, is that there are so many layers of mechanism of action that either you need to work on each one of those, or you need to kind of do that in a very systematic fashion. But before you do that, that's where I guess some of us come in. Our intent or our idea is that ultimately we are interested in trying to see what works. And in fact, my mentors, Dr. Ban and Dr. Black, we had this discussion that what works is what is proven in a double-blind randomized controlled trial. That's the only way to assess if what you are saying, it actually is happening. And so one of the ways of kind of moving forward in the area of probiotics is to say, all right, what is the evidence that we have so far from randomized controlled trials in terms of impact? And I would limit, because like a gentleman rightly pointed out, if you try to do Google, you would have 5,000 hits, and some of them will not be randomized trials, some of them will be varied kind of symptoms, and I don't want to get into all the symptoms. So we're trying to focus on what do we know at the moment about role of probiotics in childhood diseases. And that's what I will try to present two sides of the story. I'll present some of the evidence that we have tried. We did a meta-analysis some years back, but I tried to update it with the data that is available as of now, that what do we know about impact on childhood morbidities. And then also present to you, because unfortunately there are not that many studies that look into other morbidities in children, and I think our study still remains one of the only ones done in the community setting, which we will come to that, because there is a lacuna in that field. So I will present some data from there to give you a feel of what we found from that study. And before I kind of get into this, I think there was a discussion, and I would start with that there is this need of defining a probiotic. Like we understood that there can be different mechanisms, but unfortunately there is a problem. I mean, there is a problem on the other side. I mean, there is a problem that you can go to the regulatory bodies and say, we can go and claim that everything that has a live organism in it is a probiotic, But then the trouble is that then people take it to the next step and assume that because it is a probiotic, it has all the activities and efficacies of a probiotic that is, or any other probiotic that is up in the market. And that needs to be kept in mind. And this area needs to develop in that direction, that we need to have better definitions of that. So, I mean, when I am talking of the impacts of probiotic, I do not want to be quoted tomorrow as saying that any probiotic has these effects. It obviously belongs to whichever ones have been tested. Whatever is there is basically based on that strain, or based on that dosage, or based on that trial. All right. I'll skip through this very quickly. We know that diarrhea and, the idea is that diarrhea, pneumonia, and acute ear infections are important causes of morbidity, and I don't know to tell you that. And there is accumulating data that we have heard today, and from studies which suggest there could be a benefit using probiotics in a multiple symptoms or syndromes, sort of. So I already told you that I'll try to give you like a meta-analysis in the under 5 children of what we know about morbidity, especially these important morbidities related to probiotic supplementation. The issue that I want to highlight, and I'll highlight it during my talk as well, is that this area, there has been an extrapolation across the board. You know, you seem to feel that the impact on antibiotic-associated diarrhea is the same as, diarrhea in a developing country, is the same as a hospitalized child, is the same as a daycare setting, and that needs to be kept in mind, that those are not the same things. And that's why, although there is a lot of data, we need to bifurcate the data and see how does it pan in terms of different conditions, and how does it then pan in terms of the conditions that are basically important to us, depending on where you are. I mean, if you are in a hospital setting, you're treating very, sick children who need very high doses of antibiotic, it's a different condition. If you're working in a community setting and you're trying to prevent diarrhea, you're working in a different setting. So that paradigm, I would like all of us to keep in mind. Okay, so this is the data that we have from what we tried to do was, first of all, as a first cut information, try to get information on all randomized controlled trials where we felt the methodology was adequate, which were well done, and then tried to do their impact assessment and a meta-analysis. And as you can look at this graph, this is standard meta-analysis where each study, the size of the box gives you how much of a weightage it has depending on the number. This gives you the impact it had, this gives you the confidence interval, and then the bottom here gives you the summary impact that is based on these studies. Whenever I discuss this graph, I always try to emphasize on people that do not only look at this, look at all of this. So you need to look at, what do we see here? We see that most of the studies that are there have shown a beneficial impact. Most of the studies are on one side of the graph. And the other thing that you see, which is very important that I want you to look at, is the larger two studies. This was our study in India, and this was Abraham in Peru. And these were the only two studies that were actually done in a community setting. They were larger studies, and they were done in a community setting, and you see a smaller effect in those studies. That's all that you see, but overall, if you pool the data, you are seeing a significant impact on diarrhea. Now, this gives you the details of the studies, and I won't bore you with that, at the moment, but it's the same thing that it gives you, whether it was an active or a passive surveillance, and that would impact some of the quality assessments, and I'm not I mean, given the time today, I'm not going to go through all of that in detail, but it is here for you to look at it. And again, like I said, these are the only two studies that are done at the community level. Rest of the studies were basically at health facility level, either at a hospital or at a health facility. Now, what did we try to do? We tried to then say, okay, can we separate it down by antibiotic-associated diarrhea? Because that was, all the facility studies are basically focusing on antibiotic-associated diarrhea. So, this gives you now comparison by antibiotic-associated diarrhea versus others. So, you do see that there is a slightly higher benefit that occurs across the board with antibiotic-associated diarrhea, and if it's not an antibiotic-associated diarrhea, the impact is slightly lesser. That's the bottom line message. Now, the other thing that we have been discussing today, and that was the question we were asking at that point, is it, how specific is this impact based on a particular strain? Is it only, algae has an issue? Is it that there are, the trouble there is, I mean, respecting the data that was presented today in terms of laboratory investigations, again, these are small studies. The fact of the matter is that the data about is not sufficient out there to really make a comparison across the strains. When this is what you see is that there are 4 or 5 studies with algae, there are 3 studies with this, then again as you go down to body there are 2 studies there. So although it doesn't, at least from this analysis, it doesn't seem that there are drastic differences, at least in terms of diarrhea, among the strains, among different strains, as of now, as the literature is now. But one needs to keep in mind that there is a dearth of literature in this area, and there is need for more studies to really look at if there are across the strain effects, and is there a reason for choosing one over the other for diarrhea. At the moment, that evidence doesn't seem to be available. Then if you look at the other idea has been that most of the studies have been in developed countries. And again, those are either at the facilities or they are at, and as we know, the gut in both of these settings is totally different. The colonization of gut is different, how the gut responds to bacteria is different, what is normal exposure of gut is different. Then added to that, you have malnutrition where the mucosa is different. So given that, what we tried to do was to separate it out into developing country studies and developed country studies. And again, you see 2 things there. You see that there are very less studies. I mean, you got 5 studies in developing countries. You got 2 of them which are community-based studies which did not show a huge impact, which have the major kind of a, sort of weightage given the sample size of that. And then you have got 4 studies which are very small sizes and which are some of them broad kind of confidence intervals. Overall, even if you bought and said we still want to go ahead and look at the meta-analysis, you still see the same thing, that the impact that has been shown classically in the developed countries, the impact in the developing countries as so far has been little lesser. Now, but the caveat, we need all to keep in mind that there is lack of data, lack of real data from double-blind, randomized clinical trials at community level of adequate sample size with adequate outcomes. It isn't there. Then we were looking at, does it matter where the children are kind of enrolled, and as you can imagine, it does. But the trouble there again is that you got majority of the studies from hospital settings. I mean, that's the trouble. I mean, the reason that I presented these slides to you is that when you see a meta-analysis and you see all these 20 slides lined up there, you don't get a feel where are these data coming from. So you assume, a clinician in a field will assume that, what this tells me is that if a patient walks into my clinic tomorrow, that's the same. But that's not happening. And the thing that you again see, which I highlighted, is that there are only 2 community studies. I was actually told that there is probably one more community-based study available now from India. And so, but that's all we have. We do not have community-based randomized controlled trials available evaluating the impact. All right. So I will not go into this. You already know we try to look at the subclasses of the strains and all of them, but I don't think, you get the message, and so I'm not going into the details at this point in time for the sake of time. I will also not, I'm flashing this, but just to say that we did go through the whole process of doing the agar plots and doing publication bias issues, and then compensating for publication bias, and then looking at if that is impacting the results and compensating the results for that, just to say that it was done in a methodologically sound way. The other thing I wanted to share with you is the recent publication which has come on, on pneumonia, on respiratory tract infections, and these are the data from that analysis. Again, marginally small, but overall impact on areas, less number of studies. If you look at otitis media, seems to be little more impact on otitis media than on overall pneumonia. Again, antibiotic requirement for antibiotic treatments, overall some significant reduction, but studies are very few. So I guess I have, 3 minutes left to speak? Okay. So I will in 3 minutes try to, the idea was to get you that we did a study which, where we looked at a double-blind randomized trial of pre and probiotic given as a milk, with the milk base. So I will essentially, I don't think I'll skip the design. It's a double-blind randomized controlled trial at a community-based setting, involved about 624 children, 300 children per group, as you can see. And the other thing that you need to see is that both groups actually got same macronutrients. The only difference actually between the groups was, including zinc and iron, after all, and the only difference was the probiotic between the groups. So whatever difference you're seeing is that it was not only that they were getting normal diet within the milk, both the groups were getting a supplemented milk, so to say, within higher quantities of milk and iron. So this can go further, and there are 3 things that we found there, which in addition to diarrhea. First thing that was there was that the diarrhea impact, I won't go to baseline, they were comparable for everything that we tried to look at. And compliance, first was the compliance was very good, but 90% compliance in everybody. So, it was much better than we have ever had with any drug or iron or, in the community. So the other thing important was that we did see, which is not reported elsewhere, and that's why I wanted to highlight this, is that we did see, as I said, a low effect, about 8%, 9% effect on diarrhea morbidity. But in addition to diarrhea morbidity, we did see, because we were doing a constant morbidity check, there was an impact on days with fever. So there was about 5% reduction in days with fever. There was a significant decrease in days with high fever. There was a significant difference in days with severe illness, which was not only diarrheal illness, which was any illness, which included febrile illness, maybe a viral illness, where a physician basically said the child was severely sick, so we had a score there while it was sick. And there was a significant decrease in measles. The numbers are very low. So it was 5 versus 10. So we should not interpret it as 50% reduction. I wouldn't do that as an epidemiologist. But there was a reduction in measles illness. Okay. So what do I need to do? All right. Give me a minute to wind up. So that, I mean, the reason that I wanted to share, again, if you go into the diarrheal episodes, there was a decline in dysentery episodes more than simple diarrhea episodes. And days with bloody diarrhea was lower, and if you see, the need for antibiotic was lower. So obviously, what I'll not show you now that there's no time is that there was an impact on our hemoglobin. Now, this all could not have been directly responsible. Either it was responsible with the immune impacts that we have discussed in terms of the mechanism of probiotics, as well as better nutrient absorption resulting from an improvement in the gut. So it was not only a question of impact on diarrhea, which was there, but there was an impact. I think that's where I'll end. There was some effect on growth, which is again consistent. We did have an improvement in weight velocity, and again, the consistency is the same. They were getting the same diet, but there was an improvement, indicates that there was an improvement in the gut functionality that ultimately resulted in it. Thank you.